Okay, good afternoon, everyone, and thanks for making it to the home stretch here. Please help yourself to the cookies, chips, and all kinds of unhealthy stuff that we have in the back of the room. We also have lots of fruit and salad. Stay healthy with. So I am reporting out from Work Group 1, Diversity. Nick needed to leave to head to another pressing event, so here I am. Any errors you see are mine, not the work group. You are fantastic. Work Group 1, amazing. Amazing, amazing. Okay, so our goals were to bring together participants and representatives to identify how to best fund the Thrive Scholars Program, to share the CUNY workforce development plans and activities to date with any other universities and providers that are in the room. We had a great group of folks from multiple universities, from PPSs, and from community health agencies. We had unions represented. We had so many different folks. It was really lovely. And then to explore shared interests that we all are interested in. So we have 6 deliverables, and we have people who volunteered to work on them. So I feel like that's a huge success, and again, great group. So one is, we identified a big challenge about this training pipeline, about how when people enroll in school, they graduate or not, they get a job or not, they get licensed or not, they stay in the field or not, identifying the steps in that pipeline, and then working with universities that have data on this or any other data sources, such as HRSA-funded programs are required to keep data on their students. The clinical psychology programs are required to keep data on their students. So to be able to pull those data sources together with Work Group 4, of which I am also a member, to try to pull that together and take a look at what do we know and what can we learn from the internship and training opportunities that students have to try to understand how people may drop out of or stay in the pipeline. Second, focus group and survey with stakeholders on creating better alignment between training curricula and community serve. There was a lot of really great discussion around how what people are trained on is not always what is needed in the community. I would imagine we're not the only work group that brought that up. Not the first time that's come up today, but an idea of getting a focus group survey, getting some information with multiple stakeholders, community members, people who are served by clinics, people who are training in clinics, people who are trainees there, and providers, academics, all the folks that are stakeholders in this, to understand how we can better create alignment there. Third, we want to look at improving internship design and preceptor training. Some of the places that host training sites like hospitals and clinics said, we don't really always know what we need to be doing for you. We'd love to have better communication with you. And the schools were also saying sometimes we send our students to training opportunities and we're not sure what they're doing while they're there. And so getting these two folks together, and this will double as an opportunity to both look at the design of the internships and can we find some commonalities to help the training sites be better prepared and better understand the curriculum, and to help the academics have a better understanding of what's happening in the field, because many academics are no longer working in the field and we need that two-way communication. So moving that together with a deliverable of plans for preceptor training and some general principles around improving internship design. Fourth, everyone's very interested in Thrive Scholars Program. Anyone who would like to donate to the Thrive Scholars Program, please come see me, STAT. We will absolutely get that check processed right away, and it will go to a very good cause. Since everyone turned their pockets out in the meeting, but what we do have is an advisory group to create a comprehensive program that includes the CUNY student-based program, multiple university student-based program to provide tuition, and options for employers or funders to provide loan repayment programs or training positions such as residencies or other kinds of options to help get the right folks, get a more diverse population in, and to help provide the funding to offset that. Again, you can make your checks out to CUNY SPH. I will get them to the right place for that. Number 5, a CE program for behavioral health managers and leaders. We identified this as a group that is really critical in helping junior people stay in the field and making sure that they have the training that they need. Clinical training isn't always what you need to be the best kind of manager and leader. So, and that follows up off the academy work that we did. And Linda and I will be a great team moving that forward as well. And then finally, the discussion, particularly for increasing diversity, looking at people's experiences of institutional discrimination and racism that impact their willingness to stay in the field. And so doing just a couple of focus groups to understand how widespread is this as a concern. A number of people had anecdotal experience about this, but trying to look at how broad is this, what do we need to do as providers, What do we need to do as teachers, as faculty, to help make sure that these issues are addressed so that the experience of being a trainee or being in school is not something where students are shut down when they bring up these issues or when they have these concerns. Anyone from Work Group 1? Anything I missed? Okay, thank you. Work Group 1, fantastic. Let's move on to Work Group 2. Thank you. So I'm going to hand it back over to Cheryl. Let's see if we can get the slides up. And Work Group 2 will be up right away. Thank you.
Let's see if we can get it now. Yeah, so here's what I'm trying to do.
It's going to are you showing your next children?
Yeah, because I tried to
Start talking.
Yes. Go right ahead.
Okay.
They're struggling with projecting.
Sorry.
So one of the things we talked about from last year to this year we're going to build upon, and that was the pilot programs that one of which we knew about was the to integrate do integration of behavioral health with primary care, and there was a group that had been working together. So what we already over the last year to sort of identify what they were doing and what their needs were and put that in place at Columbia. So today when we met with the different systems, Northwell, there are folks from Sinai, NYU, Columbia, we identified that there's several of these pilot programs going on in systems. Some are further along, like the one that we heard about this morning in the opening session. So what we are going to do is continue that dialogue as an action step. So it not only will expand throughout the city and these health systems that are already bringing these forward and sustaining them, but expand them to opportunities now for interprofessionals to participate in those integrated behavioral projects. So where there may be a couple of medical students embedded in a integrated plan, we're now going to look at are there opportunities for other professionals to join that, where we have nurse practitioners doing some integrated work with the community, can we bring the other professionals into those? And so we're going to continue that dialogue over the course of the year.
Yeah, another suggestion was to really think about whether or not there's a way to drive programs and innovation, perhaps through an RFA that New York City could use to solicit and fund proposals for integrated and innovative integrated care programs. And maybe that wouldn't be funded by New York City, but to put something in writing about what are the kinds of programs and what are the kinds of funding that would be helpful in moving this forward.
Right, so if we wanted to continue this and sustain it, what would an RFA? So individual sites could have the idea of what they need. It could build in an RFA. They could take it to funders. They could take it somewhere else. Then the other thing, one of the themes that kept coming up is mental health first aid. And what are we doing in the professional groups to know more about mental health first aid? And when we do know about mental health first aid, how are we taking that to communities? Can we share that? Can we do that in different? So we want to do a lot more around that, and that'll help us engage in communities. In these systems, everyone seems to have communities that they are engaged with on a regular basis. So we want to now identify those communities, and these are examples from the Lower East Side, from Brooklyn, from East Harlem, from everywhere where systems are reaching out and are engaged. So how can we then work with those communities to identify the needs, but build something around mental health first aid in those communities?
Right, and the idea of mental health first aid was in part for the community, but it also in part for thinking about the workforce development, that kind of helping all providers across disciplines and across professions become more comfortable talking about mental health issues with patients. The other action item that we walked away with was really about how do we sustain this and continue the conversation, and specifically about setting up meetings over the next year, particularly within those organizations that are piloting programs in terms of integrated care, for those systems to come together throughout the year to have set points to again check in and think about how do we continue to integrate interprofessional training into those systems. The physicians work group, which met twice over the last year, to continue to have that so that what's happening at one institution can be a teaching point for other institutions that are trying to build these programs.
And then what we were also, the work group number 1, we had a lot of very similar conversations, and one of the things that kept coming up are barriers around that integration. And so I think within that that conversation of integration, we identified a number of barriers, of course, one of which is payment for those systems, but others might be regulations, schedules, access to care. So that conversation will be built into that dialogue.
Okay.
That's it. And after many hours, and thank you to our great group.
Thank you. Okay, good afternoon. Work Group 3, first of all, I want to thank all the members of Work Group 3. We had a very lively conversation, and some of the recommendations that were suggested moving forward directly will impact the work of the consortium and some of the activities that they were planning for the next 12 months. So it was great to have those objectives aligned. As far as goals, we want to achieve consensus on core skills and curriculum to prepare peer workforces. There were actually quite a few discussions that had to do with defining the core skills based on the diverse peer support workforces. So talking about whether it's family advocates or recovery advocates or traditional peer specialists, not making that assumption that all those skills are the same, and the importance and the value of making those distinctions. So we really can move forward in identifying supports for each one. It's not a one-size-fits-all. There are similarities in concepts and practices, but there are also distinguishments that we should not lose. We also plan to continue to receive feedback on research and evaluation scope. Part of one of the goals and deliverables for the consortium is to implement a survey which will be taking place in the next few months. It's very ambitious. We hope to survey the peer support workforce in New York City to get information from individuals who have experience working as peer support workers, including community health workers, and all of the other groups that I mentioned before. And we're really excited about that. We also want to identify a final list of resources and technical assistance that will be helpful to employers. Employer education is a theme that comes up over and over again. And, and what does that mean and what will be helpful? And, definitely that educating an employer isn't about, just providing a handbook or a billing code to educate them about peer support, but what resources are really out there so that they will have the information, the education needed to be able to ensure the successful integration, which includes the supervision piece. So it's a win-win for all if we can make sure that employers get those resources and those skills that they need in order to work better with peers. So the deliverables continue to be around the recommendations around a report that would come out of that survey that we hope to complete in the next few months. We will develop a guidance document around some areas that we hadn't thought about before, including guidance around interviewing recruitment and engaging peer support workers, and how we may really need to have a deeper discussion about how to look at that differently, because we know, some of the interviewing practices don't always traditionally work for our communities. I mean, sometimes the background check eliminates like half of the workforce. So we need to continue dialogues around that. We need to continue to work with other stakeholders around that. And also develop strategies and best practices to address provider education and, again, around peer and community health worker integration and supervision. Other action items include implementation of peer and community survey. I'm sorry, we mentioned that one before. And the survey will be used, again, to develop a report. We'll also use the survey to carve out the skill sets of each of these workforces. And we'll also include a component where there will be a series of, we'll be conducting a series of community consultations with a wide range of stakeholders, including peer support workers, of course, but also providers, employers, and funders of peer services. And that's what we got today. Thank you.
Okay, for those that are still following along, understand the screen is frozen, so I know it's hard to digest all this. So work group 4, what we, let's see, these are our goals. Okay, our deliverables. The first deliverable, I'm sorry? It's right here. I'm good. It's not on the screen. Okay, is for the metrics workers. So over the past year, all those that we presented in the morning, all those tables and kind of hypotheses and the data that was behind it is much more vast than what we showed you on those, although it was still a lot that we showed you. We have it actually through a report. And so the first deliverable is that, pending additional resources to help really pull all this together of what we have to date on all of those existing data resources that are out there, and the picture that it paints, at least preliminary, would be our first kind of deliverable, is to have that be a public-facing report. The second is to leverage the great work that the state OMH office is doing with NYU, doing a report on the collaborative care and the impact on costs through looking at Medicaid claims data. So that was kind of around our hypothesis around you changing delivery models and the impact that it has. So that report is going to be something that will come out soon. The third deliverable was referenced in the morning too around one of our recommendations, which is tapping into existing survey tools and data mechanisms that are already being planned, such as the various state agencies that regularly survey providers, in addition to associations and other groups such as the peer workforce, and how does our metrics advisory, what we're now calling advisory group, help to make sure that we're tapping into an already existing survey and adding and redesigning the survey questions, not maybe redesigning, probably adding, to make sure we're getting some really valuable new data sources that we've identified are currently not existent. And the fourth deliverable is we prioritize one particular thing around the analysis of projected loss of the workforce due to aging or burnout or turnover, and how does that compare to the projected supply of the workforce. So really this demand versus supply, but a particular look at why people are leaving the workforce, but not necessarily thinking that we have to replace at a 1-to-1 ratio if things are changing. It may be more, it may be less. So that would also be pending additional resources to do that analysis. And the action items to get to those 4 deliverables are really identifying the resources and key stakeholders that are not already involved in our work that are needed to achieve this set of deliverables. The second is that we've committed to continue to meet as a group. And the third is that we think could be really valuable, given that all the other work groups reference data in some way, that there's some regular dialogue, whether it's a conference call or something, amongst the chairs or co-chairs of the work groups to share and be in touch and really tap into our existing work a little bit more than I think happened the past year. So that is our 3 action items. Anything? No? That's it. Great. Thank you to work group 4. Dr. Belkin, would you like to take us home?
So we'll fix slides and send them around to everybody. How does everyone feel? Okay. I'm seeing nodding heads, but slowly nodding heads. So I want to thank you again. I want to share a thought and then give encouragement. The thought is I'm seeing a lot of overlaps in some of the recommendations and what we're building out now. For example, the work group 2 talking about, if I understood you right, mental health first aid kind of being a wedge for getting other folks, particularly trainees, out into communities the way that they connect differently to community-based places, maybe build out from there. we have a huge investment in MHFA. We can train them. We can make them trainers. We can bring. So we have resources now, operational resources, not just dollars. We don't have as many dollars as people think, because they're in operational resources to move a lot of the sorts of things that you're talking about. So I think we have to kind of gather this stuff and see where we can really attach a lot of the platforms and things that are with the Mental Health Service Corps as an opportunity. Maybe some of those places or ways to host training experiences, or even to support novel connections between settings and different training programs. So there's real tools that we have, real things happening, real boots on the ground to facilitate some of the things that we're talking about that we didn't have a year ago. And so that's really exciting and makes a lot of these things more possible. We have new ways that we work with all the PPSs, and we got to get one of them to fund some Thrive Scholars because they have workforce investment dollars. So there are these convenings and collaborative and other opportunities, operational opportunities to make some of these things happen. What we also have that we didn't have a year ago, which we mentioned at the outset, are more people, especially at CUNY. In this new center we established specifically to create more bandwidth for the kind of working through, thinking through, evaluating through a lot of the ideas that Thrive is and is percolating more of. And so we're going to bring those to bear. You will be hearing from us. The ensuing year will be about trying to work on some of these things and keeping them moving. And getting a summary of what was discussed today to you sooner than a year later. And so we're building our own machinery as these ideas are slowly maturing. I'm in this for the long haul. Transforming the New York City mental health workforce is not going to happen in a year or 2 or 5. But I think we are going down the paths that feel like the right paths. And we'll evolve them year to year and hopefully keep you all involved and busy along the way. So I want to thank you for that. Looking forward to the work to come. Again, thank our hosts, CUNY, and the team led by Cheryl and Jennifer. And thank you very much.